Part 7 of GI disorders is going to discuss Hirschsprung's disease. Another name for Hirschsprung's disease is aganglionic megacolon. When you break those words down, you'll be able to realize what this is. You all should know that a ganglion is the nerve. When we put an A in front of it, means no nerve. When you look at the word mega, it means big, and colon means it affects the colon. So put that all together, you have no nerve turns into big colon. And that, in a nutshell, is what Hirschsprung's disease is. The children are lacking the parasympathetic nerve ganglion that promotes peristalsis. Therefore, they can't propel stool forward. The defect is usually very close to the rectosigmoid junction, and so proximal to where the nerve is missing, there is dilation of the colon. The longer it goes on, the larger the colon. And then distal to the aganglionic segment, there's atrophy because that muscle really doesn't need to work to propel stool, because most of the stool that's going to come out is going to be the liquid stool that's around the constipated stool. There is a possibility of fluid and electrolyte abnormalities, but this usually is not the case. This is the same picture that's in your textbook, so take a look at it and look at it in your textbook, and it shows you where the aganglionic region is, and it's a little bit bigger than normal, and then up above it, very, very large, and it's dilated with stool and gas. And here you can really see the dilated colon. It primarily affects the large intestine, but it can affect parts of the small intestine. So the history that this kid is going to come in with is chronic constipation and passing ribbon-like stools. Sometimes we diagnose this at the time of the birth because the baby fails to pass meconium, and that's a cardinal sign in the neonate. And then we can fix it and they're fine. But other kids aren't going to be diagnosed until they're older. When they're diagnosed older, as well as a neonate, because of the backup of stool, there is going to be a palpable fecal mass. There's going to be gas, and the belly is distended. There may be some vomiting, but that isn't the general rule. Anemia can be present. Because the child doesn't eat well, they don't thrive very well either. Because every time they eat, they get a bellyache. They feel distended, they feel bloated, they have cramps, and yet they can't poop. When they're suspicious of this disorder, the initial test is doing a barium enema, and it will actually show that big colon. And then this is followed by a rectal biopsy, and that will be definitive in seeing that this tissue lacks the ganglion cells. To repair it, it's a 2 to 3 stage operation, and usually they'll start out with a temporary colostomy, and this allows the rest of the bowel to rest and regain its normal tone so that when they repair it and they take the aganglionic part off, it will be able to function immediately post-op. The second operation, they pull through innervated bowel to the point that's near the rectum, and then they resect the aganglionic portion. And then the very last part is taking the child back for a colostomy closure. Sometimes they'll do the colostomy closure at the time of the pull-through, and other times they wait for 2 separate operations. So your nursing care. Preoperatively, you might need to be doing saline enemas because they want to empty the bowel, and this helps prevent enterocolitis from occurring after surgery. So what you'll need to do is you use a 20 ml of saline and you flush it through a Foley, and then you use a 60 ml syringe, take the syringe off, and then you let it drain, and then you put in 20 mLs and you let it drain, and the input should be less than the output, because what you're trying to do is drain the stool. If nothing is coming out after you put the 20 mLs in, pull the Foley out, clear out the little holes because there's probably stool in it, reinsert and do it again. And you keep doing that until it's clear. Antibiotics may be given systemically as well as through the colonics, which would be through that washing out enema. We can also give it via an NG tube, and this will also decrease the risk of post-op infection. An NG tube may be needed to be inserted also to decompress the belly. You'll be doing abdominal girth measurements, and we measure just above the umbilicus. So go all the way around, mark with a skin marker where you put your measuring tape so that everybody after you measures in the same place. And we note that usually once a shift, unless it's increasing, in which case you're going to be doing it sometimes even hourly. This is not expected though. And we measure that in centimeters. Support the parents. This is exhausting when we're not diagnosing this until this kid is school age. They've been dealing with this for a long time, including doing saline enemas at home. You need to prepare them for the fact that their child is going to have a colostomy and they're going to have to be doing colostomy care. And also support them as they have to relinquish their child up to the surgeon for multiple operations. When the child comes back from the OR, we'll put the NG tube to low suction until we know that this gut has peristaltic activity, or if the child actually has a stool. You need to do colostomy care, and I know that you've learned that already in first and second term. So you have to take care of the stoma, monitor the stool output, provide good skin care around the stoma. Dressing changes are no different than any other dressing change, but we will not do any rectal temps. There's some psychosocial issues here, both on the part of the child as well as the parents. Now, if we're doing this on a little baby, there's no psychosocial fear, at least for the baby, but there is going to be some comfort needs. So you'll be needing to do pain assessments and administering medication for that. It's okay to hold the baby, but you want to support the parents. You need to teach them how to take care of the stoma as well as the surrounding skin. If they haven't already been administering saline enemas, then you're going to teach them how to do that just the same way that you learned. Some of the kids are going to be sent home with anal dilators because with the surgery, you don't want it to scar where it becomes stenotic. So they just get sent home with it, and then at the first post-op visit, if indeed it looks like it's stricturing, the colorectal surgeon will teach them how to actually use it. And this ends the presentation on Hirschsprung's disease.